Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone in our webinar today. This is a special webinar today about the Novomix 30 differentiation between different types of premix insulin. I would like to introduce our speaker today is Dr. Samir Ashurhani, internal medicine, endocrinology, diabetes and metabolism consultant in King Abdulaziz Specialist Hospital in Taif Diabetic Center. Also, this webinar is actually in collaboration with the Novo Nordisk pharmaceutical company. Mike is yours, Dr. Samir.
Thank you very much, Tariq. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to welcome everybody. Our talk today will be about Novomix 30 and different type of premixed insulin. So let me put the slides and to start.
Yes, go ahead.
So we will speak today about different types of premix insulin, and we will concentrate on Novomix 30 because it's available in MOH, in PHCs and diabetic centers in hospitals, and also because of the benefit of the medication and feasibility and easy to use medication. So what are the differences and benefits? Well, we will start with this case study. This is Mr. Ali. He's 62 years old. He got type 2 diabetes for 11 years. His BMI is 27 kg per square meter. His blood pressure is 160/95 millimeter mercury. His fasting plasma HbA1c is 8.3, and the patient in mixed start 30, 22 international units.
I prefer to close your video because there's still voice not clear.
Ah, sorry.
It's better, yeah.
Okay.
Thank you.
Yes. Is it closed now?
No, it's still working. Your video. You didn't find it?
I couldn't find it. Okay, just. Right.
Yeah, you can share screen now. Yeah.
Okay. So, is it okay now?
You share screen now. Share screen.
Okay, just wait.
Great.
Right?
Yeah, awesome. Keep going.
Okay. So again, this Mr. Ali, the voice is clear now?
Yeah, absolutely.
Okay, he's 62 years old. He has diabetes for 11 years with BMI 27, blood pressure 160/95, fasting blood glucose 145, HbA1c is 8.3. His glucose lowering treatment is Mixtard 30, 22 international units, BID, and metformin. He's a banker. He sometimes omitting some doses due to inconvenience, and he has frequent hypos his labs showed normal renal function. This is a classical patients we see a lot in the clinic, either in PHCs, in hospitals, in diabetic centers. So we see lots of patients like Mr. Ali. I will let you think and to take your opinion if we would switch Mr. Ali from Mixtard to Novomix 30 BID with the same doses, what would happen? So keep that in mind, think about this question, and we will move on. And after that, we will answer this question. So this study showed that there are 425 million people in the world having diabetes, and only 50% of them are diagnosed. And 50% of those who are already diagnosed received care, and 50% of people who received the care, they achieved the treatment target, and only 50% of them have the desired outcome. And this is known as the rule of halves. And we need to break this rule of halves. Excuse me? How to break that? We have to drive change where the needs are greatest. In Saudi Arabia, we have 4.3 million people having diabetes. Almost 40% of them have type 2 diabetes while they don't know that they have it. And 15,000 deaths are caused by diabetes, most likely due to diabetes complications, and that's happened annually. So this is the most famous study have been done and published in 1993 in New England Journal of Medicine, and it's called the DCCT, or the Diabetes Control and Complication Trial. And the bottom line or conclusion of this study said intensive therapy effectively delays the onset and slows the progression of diabetic retinopathy, nephropathy, and neuropathy in patients with insulin-dependent diabetes mellitus. So basically, we need to intensify the therapy of patients with diabetes to reach the goal and to prevent the complications, or at least to delay the complication. And we need to consider and to know that each patient and each special situation has their own target and their own level of glycated hemoglobin. So what would be the barriers for treatment intensification with insulin therapy? There are lots of barriers, but the most popular or the most difficult ones are hypoglycemia, complexity of the treatment, and poor treatment adherence. And poor treatment adherence, this what we can make it as preventable cause with the patients. So if we look at this Donnelly et al. Study, which was published in 2007, it showed 2/3 of patients, almost 67% of patients, have poor adherence. How did they measure the adherence of the patients? They did it with the doses taken by them. If it's 80% and more, this means that it's well adherent or good adherence. So if you look at the graph, you find almost 67% of them are poorly adherent to their medicine or injectable insulin. What would be the consequences of non-adherence and diabetes? And I think this would, anybody will answer it quickly and like a common sense, that non-adherence in diabetes is associated with significantly higher rate of hospitalization and mortality than adherent patient. But with this evidence-based study, Mekoli et al., published in 2011 in Diabetes Care Journal, it showed that all-cause hospitalization had been decreased, and it's statistically and clinically significant in adherent patients compared to non-adherent ones. And also the all-cause mortality have shown the same. In adherent patients, they have less all-cause mortality percentage. And there are so many reasons for non-adherence or non-compliance for insulin doses. Some of the patients, they are just frustrated. They are too busy because of traveling, skip meals, stress or emotional problems, injection embarrassment, either in front of colleagues or in public area. They feel embarrassed to inject themselves with insulin, and challenging to take at the same time every day. Forgetfulness, too many injections, avoid weight gain. Some of patients, they have the idea that insulin increases the weight, so they avoid weight gain by avoiding taking the insulin. And if the regimen is too complicated for the patients, different doses, if they need some corrective doses, if according to blood sugar, and if the injections are painful. So, so many reasons for the patients, and from the experience, the patients just they find any reason for themselves just to not to take the insulin. So simplification of medication dosing improves adherence. And this study, which is called Claxton trial, or Claxton et al., they did the study to measure the adherence for the patient across the timing, or how many times that would insulin be being taken per day. So if it's once daily, we will, and it's again common sense, if it's once daily, the adherence will be better than twice, and twice is better than thrice, and all of them are better than 4 times a day, or the MDI regimen. So as simple the regimen is, the adherence will be better. The other factor is fear of hypoglycemia that would conflict with treatment success for both patients and clinician. And in these 2 trials, they took the background from the patients themselves and the physicians about hypoglycemia. So they asked the patient, or reviewed the patient in type 1, which is in the left photograph. The darker blue is the type 1 diabetes. The lighter one is type 1, the darker one is, and the type 2 is the lighter. And they found in non-severe episode of hypoglycemia, 74% of patients, they have deducted the insulin dose by themselves, as compared with 43% of type 2 patients. In severe episodes, the percentage is higher, as almost 80% of type 1 diabetics, they decreased their insulin dose following major or severe hypoglycemic event, as compared to 58%. When they interviewed the physicians, and they took primary care physician in darker green, as compared to a diabetes specialist, and they asked them, would you treat your patient more aggressively if there was no concern about hypoglycemia? 72% of primary care physicians answered yes, I would aggressively treat my patients if there is no fear or no concern about hypoglycemia, as compared to almost 80% of diabetes specialists. So complex insulin regimens may impede patients' glucose control. And they found that 27.6% of patients have reported difficulties with taking insulin at prescribed time or with meals every day. And 17% of them have difficulties following healthcare professionals' instructions. While physicians share this view, with 54.5% saying patients found it difficult to comply with their insulin regimens, and 57.7% saying patients have difficulty with changing timing of insulin to meet daily needs. And if you look at it, diabetics, they have chronic disease. They have to inject themselves maybe twice, thrice, maybe 4 times a day. It would be difficult to be adherent or to be compliant every day at the same time, to check blood sugar, to take the dose at the same timing, to be compliant every day, not to forget every day. So this is difficult for the patient, and even physicians find it difficult for them. So the conclusion of this, the more complex the treatment regimen, the lower the adherence will be. And we can make it the vice versa. The more easiest the treatment regimen, the higher the adherence will be. So according to the 2018 ADA guidelines for intensifying injectable therapies, if HbA1c above target despite dual or triple therapy, if the patient, we have to consider GLP-1 receptor agonist, as they showed marked and huge benefit in the cardiovascular point of view. If the patient is already in GLP-1 receptor agonist, or if he's contraindicated for that, or if insulin is preferred for this patient, so we can start the basal insulin. If HbA1c is still above the target despite adequate titrated basal insulin, so we can add prandial insulin, usually 1 dose, and we usually add this one with the big meal, with the biggest meal of the day. If his biggest meal is the lunch, as most of the people, it will be with the lunch. If it's with dinner, so we will add it with the dinner. And of this, if it's HbA1c still above the target, we can stepwise additional injections of prandial insulin, like twice daily, like with lunch and with dinner, or 3 times a day. And we can consider twice daily or thrice daily premix insulin regimen. And this was added recently, the premix insulin. If HbA1c is still above the target after all of that, we have to proceed to full basal bolus regimen. If HbA1c doesn't improve, review need for basal bolus regimen. And this is the 2020 ADA guidelines, and it's more complicated than the previous one, but it says the same idea. So how is the biphasic insulin aspart 30 or Novomix 30 is different from biphasic human insulin 30 or mixed-start? So biphasic insulin aspart 30, Novomix, is a premix suspension, consists of soluble insulin aspart as 30% of insulin aspart and protaminated insulin aspart of 70%. While the biphasic human insulin 30 or mixed-start is a premix suspension of regular human insulin, 30%, and NPH insulin of 70%. So they are 2 different insulins, regular insulin and NPH. While the Novomix, it's the same insulin, which is aspart, the main component, but they added protamine crystal to it, or being protaminated to be long or intermediate acting. Why is that is an important information? Because for insulin to be used, the best insulin to be used is the insulin that mimics the physiological insulin that's been secreted by the body. The conventional premix, the human insulin 30, does not mimic physiological insulin secretion. So Mixtard, or the biphasic insulin, human insulin, doesn't mimic the physiological insulin. Why? This is the physiological insulin profile. It has basal component, and it has peak, which starts to peak about 5 to 10 minutes after ingestion of the food. So it's glucose-dependent insulin secretion after ingestion of the meal. It has to have some peak, which decline slowly over and to be normalized about 2 hours after the meal. So this is the soluble insulin or regular insulin, which doesn't reach the peak after ingestion of the food. And this is the MPH, which almost works with the basal insulin, but it also has longer action. And this is the Mixtard. Mixtard doesn't reach the peak, and it takes time for the insulin itself to act. So onset of action is delayed, and it doesn't reach the peak after the meal ingestion, and it takes a longer time to re-normalize. So this one doesn't mimic the physiological insulin secretion. That would cause risk of hyperglycemia with decreased peak, and risk of hypoglycemia with longer duration of action, and postprandial glucose excursion of postprandial glucose will be higher because of the delayed onset of action. This is Novomix 30 that would mimic physiological insulin secretion. If we looked at it, this is the rapid-acting insulin aspart, which is the 30% component of the Novomix 30, which provides prandial coverage because the onset of action, it's almost 5 to 10 minutes after the injection. So you can take it just before the meal or at the meal time, or even you can take it within the meal. And this is the 70% protaminated insulin aspart, which give the longer duration of basal insulin. And this is the Novomix, or biphasic insulin aspart 30, which almost mimics the physiological insulin secretion. So better postprandial glucose control, lower risk of hypoglycemia, and rapid onset of action. This is a Nagar et al. Study that studied the switching patients. If you remember our case study or our patient Ali in the beginning of the webinar. So this study done for patients switched from biphasic human insulin 30 or Mixtard to Novomix 30, which showed reduction in HbA1c by 1.7% with significant B value after 6 months of taking Novomix 30. And it showed also better fasting plasma glucose and better postprandial glucose. Why? Because of the pharmacokinetics, pharmacodynamics of the insulin that mimics the physiological insulin secreted by the pancreas or beta cells of the body. Hypoglycemia reduction following switching from Mixtard to Novomix 30. Baseline, the dark blue is the baseline on human premix or Mixtard, And after 6 months, the lighter one, after 6 months of Novomix 30, they found 96% reduction of major hypoglycemic events. And they found 62% reduction of minor hypoglycemic event from 5.3 events per patient per year to 2 events per patient per year. So if we go back to our patient, Mr. Ali, of 11 years of type 2 diabetes, and he was on Mixtard 30, 22 international units BID and metformin. Your opinion, if we switch him from Novo or from Mixtard to Novomix, according to the data that we just discussed, it has to be better control. It has to be less hypos. If you remember that he has frequent hypos, and he sometimes doesn't take the medication because of inconvenience. It might be hypoglycemia. So what happened with him? He was switched from Mixtard 30 to Novomix 30 with 22 international units BID, and there was no reported hypoglycemic events. His glycemic readings after 4 months of switching, HbA1c, glycated hemoglobin, was 7%, so perfectly at the target because his renal function is normal. His mean fasting plasma glucose is 105 milligram per deciliter, and 2 hours postprandial glucose is 146 milligram per deciliter. So the patient showed better benefit on Novomix 30. But at this time, I have to tell you that each patient has his own situation, his own, we have to tailor the medication, the regimen according to the patient's needs, according to the patient feasibility, to the patient health and of the providers of healthcare provider with him at home. So each patient has to take the regimen that is better for him. Hermansen et al. Study, which is for studying pharmacokinetics and pharmacodynamics of Novomix 30 versus biphasic insulin Lispro 25 or homolog mix 25 versus the biphasic human insulin 30 or Mixtard 30. This study design is a little bit complicated, but I will just explain it for you. They are 45 patients started on Mixtard. The dotted line, it's for Novomix 30. The dashed or striped line for Lispro Mix 25 or homolog Mix 25, and the continuous line for Mixtard. They started all the patients on Mixtard. Then they made a crossover trial. This crossover trial, they started patients in the dotted line on Novomix 30 at meal, and 15 patients on homolog mix, then 15 patients on Mixtard. They continued in Mixtard. Then they measured the postprandial glucose. About 0 to 5 hours postprandially to measure the glucose excursion postprandially. Then they reversed them back on Mixtard for 5 days for washout. Then again, the patient received Mixtard, who were in Mixtard, they received Novomix 30. The one were in Lispro, they received Mixtard, and the one on Novomix, they received homolog mix. And they did it as crossover, then they finished the study. What did they find? they find that patients receiving Novomix and homolog mix 25 have less postprandial excursion than patients on Mixtard. Because again, patient with an aspart or homolog or Lispro, they have the insulin that mimics the insulin stored in the body and excreted by the beta cells of the body. So they have less postprandial excursion. But they found the patient in Novomix 30 have 10% less postprandial excursion than the patient on homolog mix. So again, with the rapid acting insulin, there was preference of Novomix 30 over homolog mix 25. And this is the Fracosi trial, which studied the high mix insulin versus the low mix. And it's a randomized open label multi-center study. It studied insulin experience of type 2 diabetics with 302 patients. Half of them on insulin Lispro mix 50-50 TID or homolog mix 50%, and biphasic insulin aspart 70-30 or insulin Lispro mix 75-25. For 16 weeks, the HbA1c was similar with no significant differences between the two arms. Fasting plasma glucose was significantly lower with the BID arm. Weight gain was significantly higher with the TID arm. Again, the homolog mix 50%, half of the component are rapid acting and half of them are intermediate to long acting. So weight gain would be expected to be higher in such patients receiving 50-50. Overall, hypos were the same. But again, there is no insulin better than the other. There is certain patients need certain types of insulin, like insulin homolog mix 50%. Again, it has no significant difference in the matter of HbA1c reduction, but it has increased weight gain. But such certain types of patients have to use such insulin, like patients who are binging or taking lots of food the whole day, or the 3 meals are heavy meals, so they need such insulin to control their postprandial insulin glucose and to have longer acting insulin. So in conclusion, in patients with type 2 diabetes who haven't achieved adequate glycemic control with low mix 75-25 and biphasic insulin aspart 70-30 BID plus metformin, and who are not candidates for basal bolus therapy, switching either to treatment with low mix 50-50 TID or to progressive titration of premix insulin analogs, BID didn't produce sufficient evidence of a difference of overall glycemic control between the two treatment groups. This is the 1-2-3 study design and method. They started the patient on once daily injection. It was pre-dinner for 16 weeks. And they start with 12 units at the dinner. If HbA1c is 6.5 or less, they end the study. If it's still more than 6.5, they go to BID injections and they stop secretagogues. Phase 2, the BID injections, they give a pre-breakfast and dinner for 16 weeks. They add 3 units at breakfast of fasting blood glucose 110 or less, and 6 units of the breakfast, pre-breakfast or fasting blood glucose 110 or more, more than 110. If HbA1c 6.5 or less, they end the study. And if it's still more than 6.5, they go to the TID dose. TID, they give it for 16 weeks and they add 3 units at lunch and titrate according to blood postprandial blood glucose. 123 study showed 2% reduction in glycated hemoglobin with OD, BID, or TID biphasic insulin aspart 30. And here I have to add a note that some physicians think that Novomix 30 cannot be given 3 times a day. And this is a wrong, I don't know, fact or myth. And physicians, they don't use it for 3 times. We can use it 3 times a day. So from glycated hemoglobin, 8.6 at the baseline had been decreased to 6.6 with OD, BID, TID. If the target 6.5 or less according to ACE guidelines, with OD dose, 21% of patients have reached the target, 52% with OD, BID dose have reached 6.5 or less, 60% have reached the target OD, BID, or TID. If it's according to the ADA guideline and the target is less than 7, on OD dose, 41% of the patients have reached the target, 70% of OD, BID have reached the target, and 77% of OD, BID, TID dose reach the target. Okay, Novomix 30 titration algorithm. Some physician would ask, how would I titrate, increase, decrease the dose, or make it the same, make no change? So when you follow your patient without glucose check, there is no benefit of seeing diabetic patient. So always ask your patients to bring their glucose SMBG, glucose check at home with them, at least for the recent 2 weeks prior to the visit. If fasting blood glucose or pre-dinner SMBG 80 milligram per deciliter or less, or if it's 5 millimole for less than 4.4, so you need to decrease 2 units. If fasting blood glucose or the pre-dinner 80 to 110, or from 4.4 to 6.1 millimole per liter, so make no change. If it's 111 to 140, so you need to increase 2 units. If 141 to 180, so you need to add 4 units. If it's more than 180, you need to add 6 units to the previous dose. Okay, what about the timing? Dose to titrate according to the timing of blood glucose measurement used for dose titration. If the patient is taken once daily, so you need to check pre-breakfast. If it's taken twice daily, so the patient need to check his blood glucose pre-dinner and pre-breakfast. If 3 times a day, so pre-lunch, pre-dinner, and pre-breakfast. What about the consensus algorithm for biphasic insulin aspart 30 intensification? If biphasic or Novomix 30 OD pre-dinner or Novomix 30 is BID, so we check fasting plasma glucose and or pre-dinner blood glucose. If it's 4 to 6 millimole or 73 to 110 milligram per deciliter, and if HbA1c more than 7, we can to switch. If he is on OD, we can add it to BID. If he is on BID, we can increase it to TID. And this is again according to the patient preferred target. Like renal patient, their A1C target is not 7, it would be 7.5 to 8. If the patient had already cardiovascular events, like a previous MI or ischemic heart disease, so their target is not 7 anymore. It has to be reaching from 7.5 to 8 again. So it's according to the patient preferred target. So we speak right here generally for the most of the patients that they need intensified therapy with target A1C 7 or less. If fasting blood glucose or plasma glucose and or pre-dinner blood glucose more than 6 or more than 110, then titrate Novomix 30 OD or BID to achieve fasting plasma glucose, and or pre-dinner plasma glucose less than 6, or if hypoglycemia occurs, then we need to switch from BID to TID. So in summary, hypoglycemia and treatment complexity are major barriers in diabetes treatment. Biphasic insulin aspart 30 offers a better pharmacological profile compared with biphasic human insulin 30 or mixed 30. Biphasic insulin aspart 30 offers the patients better efficacy and safety with a lower risk of hypoglycemia versus other premix insulin as well. And thank you for everybody, and it's now the time for questions if anybody has a question.
Yeah, thank you, Doctor, for informative lecture. We're gonna receive all questions in the box of Q&A. You can find there a small box is written there is Q&A. Please write down and type your question, and Dr. Samir is gonna answer all the questions. Okay, I think, all right. I'm gonna give the mic to the Dr. Khaja Yaminuddin. I think he wanna share some experience.
Okay.
Thank you so much, Dr. Samir, for a very wonderful and comprehensive presentation, especially in today's time and premix insulin is losing its hope, and nice case discussion as well. In my opinion, as you have discussed very nicely, if we are changing any patients from mixed out to Novomix, definitely they play a very vital role, and patient will be happy to take 2 injections rather than taking 4 injections MDI. So in a way, I agree and concur with your opinion as well that this definitely will help in reducing the HbA1c targets for our patients. Thanks a lot for your presentation.
Thank you very much, Dr. Khaja. We're gonna take Dr. Mahmoud Sagar. If we're gonna share his experience too. Dr. Mahmoud Sagar. Are you there, Dr. Mahmoud? Hello? Dr. Mahmoud? Mr. Hamid Dalbar, are you there? You can share if you want. If you have, hello? Mr. Hamid?
Yes, Mr. Tariq. Just I want to thank Dr. Samir for this informative presentation and nice presentation. And I don't have any experience. Just I want to thank all attendees and the meetings. That's it. Thank you all.
All right, thank you very much.
Thank you.
Dr. Mahmoud will be with us, or we're gonna wait for him? All right. Would like today thank Dr. Samir about the informative lecture about the.
Mr. Tariq?
Yes, please. Yes, Mike is yours. Do you want to hear anything?
Yeah, there are some questions from.
Yeah,
Dr.
go ahead. Let's take them. Yeah, no worries.
He's asking about the Novomix 30, if it can be given 3 times a day, and what when would be the third dose and how much it would be the third dose. And he said most of physicians, they said only 10% for the third dose. Actually, according to the guidelines, if we start a brandial insulin, it has to be almost 10% of the basal dose, then we escalate it up. The third dose will be with the lunch. If you started first with breakfast, then with dinner, then the third dose, if it's still uncontrolled, it will be with the lunch. And we will start with the lowest dose, then we will titrate it according to the blood sugar. Dr. Abdullah Al-Bargi also has a question. He said, is there any comparison between Novomix 30 and basal bolus? Yes, there are some studies about the basal bolus and Novomix, and between they were run more, what I remember, maybe 4 or 5 studies, and it's not in the context of this lecture, because it compare the premixed insulins. But to answer the question, there is what's called Galapagos trial. Hello?
Yeah, we're with you. No worries.
Yeah.
Keep going.
Galapagos trial, which compared the Novomix 30 with insulin glargine with glolazine, plus minus glolazine. For some patients, they received it. And they found that when they compared, it showed a better reduction or greater reduction of HbA1c in the Novomix group. And the A1C was, there was no difference, but the postprandial glucose was better in the Novomix group.
We are happy today because Dr. Abdullah Bargi is with us today. It's a great time, and we are very grateful because he's with us today. Thank you, Dr. Abdullah Bargi. Any further questions? We are here. We're going to hear you. We're going to answer your question. All right. I think it's a time for closing. I thank you, Mr. Umar. Mr. Umar.
السلام عليكم.
ورحمة الله وبركاته. حيا بك.
أهلا وسهلا بالجميع.
أهلا وسهلا.
أهلا وسهلا بك دكتور سمير، كيف حالك؟ طيب إن شاء الله.
يسلمك، حياك الله.
شرفنا الصراحة بوجودك، الله يعطيك الصحة والعافية. محاضرة جدا جميلة، وخاصة إن هذه الدورة لفئة محددة لجميع الأطباء بالرعاية الصحية. أشكر جميع الحضور على تسجيلهم في الدورة هذه، وأتمنى إن شاء الله إنه نشوفهم في لقاءات قادمة بإذن الله. هذه شهادة شكر دكتور سمير نقدمها لساعدتكم على مجهودك في خلال الأوقات القيمة الصراحة اللي سويتها لنا خلال الفترة هذه، خلال الدورة. الله يعطيك الصحة والعافية، وإن شاء الله ما تكون هذا آخر لقاء. بالعكس احنا نسعد ونفتخر بوجود أطباء عندنا في صحة الطائف ما شاء الله تبارك الله، لهم المعرفة والتخصص في مجال الرعاية الصحية. الله يعطيك الصحة والعافية. هذه الدورة طبعا هي بالتعاون مع شركة نوفا. الدكتور سمير ما شاء الله تبارك الله يعني خلال الفترة السابقة يعني كان مجهود جبار بينه وبين الشركة لإقامة هذه الدورة. الله يعطيك الصحة والعافية دكتور سمير.
الشكر لكم واشكركم على التنظيم واشكر شركه نوفو نوردسك والله يعطيكم العافيه والشكر للحضور جميعا اللي اثروا اللقاء والله يعطيكم العافيه واتمنى انه يكون مفيد للجميع.
الله يعطيكم الصحه والعافيه جميعا.
بإذن
بارك
الله.
الله فيكم جميعا. طبعا بكره حيكون معنا الاستاذه الهام احمد عمر هوساوي في كورس جديد عن اليه تنظيم ملف الطبي بالمستشفيات. فحياكم الله جميعا. Thank you very much. We're going to close right now. Don't miss the course tomorrow about the how can regulation about the medical records in the hospital. All right. Thank you very much. Thank you for your time. We're going to closing Ryan. Thank you very much. إذا عندك أي كلمة. Do you have anything to add, Dr. Samir? We're going to close it now.
العافيه والشكر للجميع. شكرا
Thank you.
لكم.
Thank you very much. Bye bye.